Thanks for those kind comments, David. And I just want to say that I really appreciate being invited to this meeting. And Lauren, I really appreciated your introductory comments. Your comments, David, reminded me that in so many ways we're all part of a team. I think that we all are learning from one another, and none of us has sufficient knowledge to be able to move this field forward. So I think that this kind of forum is terrific because it gives us an opportunity to deepen our understanding of one another's work and to move our work collectively forward. My guess is that all of us in the room have kind of a combination of commitment to making the world a better place and to do so with a really deep, rigorous approach to figuring out how can we spend our scarce public resources in a more effective way. So I'd like to share with you the work that my colleagues and I have been doing for the last 3 decades or so to develop and test and try to scale the Nurse-Family Partnership. Some of you may know that the Nurse-Family Partnership is a program of prenatal and infancy home visiting by nurses for low-income mothers having their first babies. We think that focusing on women in poverty having their first babies is particularly important because in poverty, women experience a lot of adversity, and those adversities end up interfering with their capacities to care well for themselves and their children. We focus on women having their first babies because that ends up focusing our intervention on a large portion of teens whose development is not yet formed and who are going through major life biological transitions because of the hormones that are associated with pregnancy and with caring for that first child. So the brain is quite plastic, and the opportunities to do good and bad are particularly sensitive, particularly salient at this point in human development. So women having their first babies in the US, at least in Medicaid eligible populations, constitute about 40% of the population. We think that the intervention is particularly important because the reason it's been successful in our trials is that it aligns with something deep inside all of us as human beings. And that's our biological drive to protect our children. And to the extent these interventions that we develop don't simply come from the outside, they have to pay attention and align with something that is fundamentally human in all of us. And that, in this particular case with the NFP, it's to protect our children. And we think that the program also has a certain kind of sustained and enduring impact across populations and over time, because we've tried to be as clear as possible about what it is we're trying to accomplish and how we're going to do that. And we've tried to use that sense of, if you want, model integrity to create a sense of coherence for communities and for organizations and for nurses and for families themselves about what it is we're trying to accomplish and how we're getting there. Now, the nurses have 3 major goals. The first is to help women improve the outcomes of pregnancy by improving their prenatal health. The second is to improve the child's subsequent health and development by helping parents provide more competent care of the baby in the first 2 years of life. And the third is to help improve mothers' health and economic self-sufficiency by helping them develop a vision for what their lives might be like, and to think carefully about how the decisions they make for themselves will affect their abilities to protect themselves and to protect their children, with a particular focus on planning the timing of subsequent pregnancies, completing educations, finding work. We've tested this program in 3 separate randomized controlled trials for over the last 35 years or so. First in Elmira, New York, with a sample of low-income whites, then in Memphis, Tennessee, and what is pretty close to an effectiveness trial with low-income, really disadvantaged African-American families in Memphis, Tennessee, and then more recently in Denver with a sample that includes a large portion of Hispanics, and where we were able to test the relative impact of the program when delivered by nurses versus people hired from the community. Many people said to us when we first started reporting the results of the, let's say, Elmira trial, they said, yeah, that's great, but something you can get greater impacts if you hire people from the community because they align there will be less social distance between the families who you're serving and the families and the service providers. And so you can save money and cost and create an impact, greater impact, if you deliver it with paraprofessional visitors. Now, this slide shows those outcomes that we have the greatest confidence we can affect with this program because we've seen its impacts across different populations at different points in our country's history with different trials and so forth. We are confident that we can improve prenatal health. And in particular, we're confident we can reduce prenatal tobacco use. And most of you know that prenatal tobacco use is the single most important adverse influence on fetal growth and development that's out there, and it's prevalent. We've also seen significant reductions in hypertensive disorders of pregnancy. We've seen replicated effects on children's injuries revealed in the medical record, and especially reductions in days hospitalized for injuries because of, for serious things. We've seen significant improvements in children's language development and school readiness that is consistently moderated by mother's own psychological resources. That is her intellectual functioning, her sense of control of her life circumstances, her mental health. It's when mothers are least capable of living in poverty and caring well for their children that bad things happen to their children in the form of both injuries and compromised intellectual development and so forth. And it's that group for whom the program is producing the most consistent effects on school readiness and language. We see consistent effects on children's behavioral regulation at school entry, reductions in children's depression in late childhood and early adolescence. We see significant reductions in children's substance use, significant reductions in maternal behavioral impairments due to substance use, increases in the intervals between the births of first and second children, increases in maternal employment, and reductions in families' welfare and food stamp use. One of the findings that gave the program some attention was its significant reduction in our first trial in Elmira, New York, in rates of state-verified reports of child abuse and neglect. You can see here that there was a group that was visited during pregnancy alone, not followed up after delivery of the child. This group fell right in between the control group and the group that received nurse visitation during pregnancy and infancy. We think that the use of state-verified reports of child abuse and neglect to ascertain program impact on maltreatment is a lousy measure. And we think it's a lousy measure because we're only picking up a small portion of the maltreatment that actually exists, and there's ascertainment of surveillance bias. Nurses are required by law to report maltreatment that they see. So, and there is tremendous community by community variation in the extent to which maltreatment is thoroughly ascertained. We know that since the Great Recession in 2008, the rates of maltreatment reports went down, but the rates of child abuse-related fatalities went up. That should tell you something. We see significant reductions in arrests to children through age 19, but this effect in the second half of adolescence is limited to females. And exactly why that's true, I don't know. We see this slide shows the impact of the program on a whole host of maternal and child outcomes in our Denver trial, and what you see is that the group visited by paraprofessionals had effects that were roughly half that we've seen for nurses. The Washington State Institute for Public Policy has estimated that there's about a $13,000 return on investment in the program. Recent analyses by Ted Miller from the Pacific Institute for Research and Evaluation suggest much larger economic returns. The Coalition for Evidence-Based Policy, many of you know, has been established to focus policy attention on government waste and how government might be able to focus its scarce resources on programs that have very strong evidentiary standards. And by very strong evidentiary standards, they mean well-designed and conducted randomized controlled trials, replicated findings, studies conducted in community settings where there are sizable and sustained effects, and where the outcomes are of clear public health, educational, social significance. We're honored to have been identified as the only early childhood program that meets the coalition's top tier of evidence. Now, since 1977, this slide sort of summarizes the work that we've been doing in sort of developing, testing, and now replicating the NFP. We held off for 20 years before offering up the program for public investment because, honestly, two things. I wasn't sure, personally, that the findings would replicate, and I didn't want to be in a position of promoting a program just because our team happened to develop it. I needed to know that the findings were real. And I wasn't convinced that we really knew how to effectively replicate the program. So in 1996, with an invitation from the U.S. Justice Department, we started some small-scale community replication and learned from that experience. We eventually created a nonprofit organization known as the Nurse Family Partnership National Service Office, and over time have been replicating the program so that today it's operating in over 550 counties and serving 27 to 28,000 families. Now, this organization, the Nurse Family Partnership, is organized around these major functions. We are quite convinced that in order to effectively replicate this program, at least, we need to have very strong community, organizational, and state commitment and capacity to develop the program well. Just to give you an example, when we first started this work back in the mid to late 1980s, that is the replication work, I was kind of seduced by leaders in one state to develop the program like that overnight. And I've regretted that for a long time because what we've seen is that level of local ownership and commitment to developing the program well was never built. And the result of that is that the quality of program implementation in that particular state really suffers. There are other states where we have really invested and learned a lot in our collaboration with Invest in Kids and Lisa Hill, who is here and will be speaking in a moment, that building that kind of local ownership, transfer of ownership of this work is crucial to the sustainability and quality of implementation. And so we also believe that the success of this kind of work, at least with the Nurse Family Partnership, depends on really thoroughgoing education and ongoing consultation of nurses. That we need to articulate the program well in visit-by-visit guidelines and a corresponding information system that will allow us to monitor ongoing features of program implementation. And that system needs to be not too burdensome. In the original trial in Elmira, I tried to learn everything about program implementation. And the result of that was that it was way too burdensome. And honestly, I'm lucky that these nurses still talk to me today because they could have left. And what happened is that I ended up scaling back the kind of information we were requiring of them to enter into the system because it was just unrealistic based on the demands of delivering the program. We have used this information system, that original system that was actually set in motion with our Memphis trial, now has served as the framework for guiding and gathering information on program implementation as the NFP is implemented around the world. We've used that information to assess key features of program implementation and outcome, and we use that information to invoke research and efforts to improve the replication of the program as well as the fundamental program model itself, because we believe that the NFP is a work in progress. It's not a final product. There are subpopulations for whom the program is not working. There are ways in which the program is not working. We need to figure out how to do a better job. And that kind of commitment to rigorous development of innovations in the model and replication is really part of what we're all about today. The early phases of program implementation were funded through a variety of sources of funds. After President Obama was elected president in 2008, I was contacted by the transition team and asked about what it would take to scale up the nurse-family partnership. And that led to the president's first budget blueprint consisting of an $8.6 billion request to Congress that would call for a nurse home visiting program for low-income first-time mothers and so forth. And it was designed over that 10-year period to serve, at the end of the 10-year period, to serve all Medicaid-eligible women having first babies in the country. As it went through Congress, ours is a complex democracy, in case anyone hasn't noticed. It's what Congress actually allocated was $1.5 billion over a 5-year period that included provisions for funding a whole host of evidence-based home visiting programs. That money was to run out at the end of 2014, and just last night I understand that there was a budget that was passed that continues the program through the first 6 months of 2015. As Lauren indicated earlier, there are these additional data gathering requirements that come along with that money that honestly do create challenges for the NFP as it's being rolled out, and sorting out exactly what kind of additional data gathering and so forth is really needed when you've got a program that needs to deliver at scale and efficiently is really something that I think we need to discuss. I really am thrilled that there is going to be a set of independent randomized controlled trials of the program as part of this initiative through My Hope and Strong Start. We may get around to that. I think that there is growing evidence that the government is using evidence to inform policy and practice, and that's one of the reasons I really appreciated Lauren's comments this morning. I actually think that it's tenuous. I think it's challenging. I work in the UK where there is less complexity, where once in their parliamentary system, once you have a government that's won the election, they can set policy and funding for programs that just get rolled out. And here we've got to compromise. And I think that there is a fundamental question about whether evidence-based programs can be built. Well, to what degree can evidence-based programs be built on compromise? We should be asking that question, I think. There is going to be a current proposal to expand McV over the next 10 years to the tune of $15 billion using an added tax on tobacco. And yes, in our case, part of the fact that this McV has not funded the NFP to the extent that I think the administration originally intended, there are increasing efforts to use social impact bonds as a means for funding the program at the state level. And some of that kind of work is now going on in New York State and South Carolina. The program is in about 530 counties. Here's the map in the US. We've been doing this work on international replication, where part of the deal involves our expecting these other societies to develop, adapt, and conduct large-scale, independent, randomized controlled trials of the program. And I'm not going to spend time on going over this because it just summarizes our approach to thinking about how you move an evidence-based program through stages of trials and testing and figuring out what are the essential elements. How can you use your community replication effort and information that comes back from that, both US on the international side, to improve the model and the replication. And we're figuring out how to improve the model itself through research focused on these topics that you see on this slide. And this, I have some confidence, is what actually brings all of us together this morning. Thank you.